where I would like to introduce Dr. Stephanie Feldman, who is our very own cardiologist at Weill Cornell, who specializes in cardiology for cancer patients. And so she's going to talk to us about cardiovascular health for the MPN patients. Dr. Feldman.
Good morning. First, I'd like to say to Gay, thank you so much for having me. I tell your patients I see your picture in Epic all the time, but it's really nice to see you in person. And thank you to the organization for having me. I will start with my disclosures, which I have no relevant financial disclosures, but I'm a cardiologist. And so you say, what is a cardiologist doing at this symposium? And so I actually had a really nice lead in. So thank you very much for that. And I'm always excited to hear people talk about statins besides cardiology. So happy to talk a little bit about statins. So my objectives for you today, you're all adult learners, so I figured I'd give you a sense as to where we're going or what I'm hoping to do today. We're going to define cardio-oncology, because that's technically what I am. I'm a cardio-oncologist. I want you to recognize the connection between cancer and cardiovascular disease, and to identify the potential cardiac toxicities associated with the MPN, as well as really minimally, but the MPN treatments we'll talk about. And then my goal for today, and I hope we spend the majority of the time, is providing you, the patients, with strategies to improve your cardiovascular health, wherever you are in your MPN journey. And so first I will tell you, because I have to advertise my field, is what is cardio-oncology? So it's an emerging field, and it's dedicated to the prevention, diagnosis, and management of cardiovascular disease in patients with cancer or cancer patients before, during, and after cancer therapy. Most people think I take care of patients who have cancers in the heart. That's really a very minimal part of what I do. I really take care of patients like yourself. So I always think it's important to know why is this talk relevant to me, and why is this important in 2024? Well, this is a little bit older data, but if we think about what are the most common causes of death in the United States, those are cardiovascular disease and cancer. So they're relevant. We also know that because of my colleagues in the room here at Cornell and across the world, that we are really improving the diagnosis of cancer, finding cancer earlier, and also improving the treatment of cancer. So we are expected in the year of 2024 to see about 2 million cases of cancer diagnosed. However, we are also seeing the number of patients who have been diagnosed with cancer surviving. So patients who have cancer or exposed to potential cardiotoxic therapies are living longer and able to have some of the side effects of their disease therapies, and developing cardiovascular disease. So what's the connection between cancer and cardiovascular disease? I think it's important to know that while we worry about the cancer diagnosis and dying of our cancer, more than 1 in 10 patients with cancer actually die of cardiovascular disease. So it's equally as important to think about treating your cancer as well as cardiovascular disease. We know that patients with cancer are at higher risk than the average patient who doesn't have cancer for dying of cardiovascular disease. So what's the connection? Well, there's shared risk factors. Those are things like age, high blood pressure, hypertension, abnormal cholesterol, diabetes, fat, particularly in the abdominal area, which is more cardiotoxic, tobacco use, and then the inflammatory state. So the inflammatory state gets us a little bit to the cancer-related risk factors. So particularly in the MPN, you've heard about already, and you'll be hearing about the hypercoagulability, increased risk for blood clots. There's also risk of direct effects related to the cancer itself, or tumor is used here in the slide, but really just the overall milieu of inflammation caused by cancer. And then less so in the MPN, I would say, but cancer therapies potentially can cause issues with the heart, which is a lot of what I focus on. And so before I go deep into how we're going to prevent issues, I figured for those in the room who are not cardiologists and for those of you who are patients, I give you a quick spiel about cardiology, Cardiology 101. And so if you're sitting in my office as a patient, and my nurses and nurse practitioners will tell you almost every EKG in my office on the back has this drawing on it. And so I think the heart is a beautiful but complicated organ. And I think in order to think about the heart and the things that we're worried about and how to prevent those issues, we have to understand the basics of the heart. So the heart's got three main parts to it. It's got plumbing, the heart is a pump, and the heart has electricity. So when we talk about the plumbing, here's a picture of what the heart looks like, and this is what the plumbing is. The plumbing is the arteries. The heart has three major blood vessels that supply the nutrients to the heart. When people are worried about the heart, usually they're worried about having a heart attack. A heart attack is a plumbing problem. It's getting a blockage in that artery. You can have an acute blockage in that artery, or you can have plaque buildup over time in that plumbing system. So that's the plumbing. I list for you some of the words you may hear or have had friends describe to you related to what can happen to the plumbing. A heart attack. The other medical terms would be an acute myocardial infarction, a ST segment elevation MI, or STEMI, or an NSTEMI. These are words you also may have heard if you like shows like I do, Grey's Anatomy. And then the other term related to the plumbing is coronary artery disease. And so if the heart is not getting enough blood flow, you can have angina or angina. That is related to a plumbing problem. Next, I've got a nice video for you here because my pictures weren't going to cut it. And so, maybe it's not going to work for us. Here we go. So, all right, the heart's a pump. This is the main job or the role of the heart. So the heart is a pump. It pumps blood throughout your body. And when we see in this picture here, the heart really is made up of four chambers. I'll tell you the chamber on the left side here is the left ventricle that really does the majority of the work of the heart. The heart pumps blood from the right side to the lungs. We will talk a little bit about the artery that goes from the right side of the heart to the lungs is the pulmonary artery that can develop issues. We also will talk about the left ventricle, I call it the workhorse of the heart, that really is pumping blood to your brain, to the rest of your body, and can have a normal pump function. It can get stiff over time, or it can get weak over time. The medical terms we think about for heart pump issues are congestive heart failure, which I know as a patient is a really scary term. For me as a cardiologist, a little bit less scary, and I hope to obviously prevent that, but take a little bit of the stigma away from congestive heart failure. There are other terms you may hear: heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, or as they are colloquially known as HFpEF and HFrEF, if you hear these terms come up. The heart also has doors in it, the valves that open and close that prevent blood flow from backing up. The valves can be not closing perfectly. That means that they're leaky. Or the valves cannot open totally normally. The valves can have stenosis. And the last thing that we will talk about today is the pressures going from the heart to the lungs. That's the pulmonary artery, and we can have high pressures there or pulmonary hypertension. Last on your journey of cardiology learning is electricity. So the heart has an electrical system that tells the heart to pump and to do its job. If everything's going normally, you have electricity go from the top of the heart to the bottom of the heart. And this is the squiggles on the piece of paper that if your doctor gets an electrocardiogram, an EKG, this is where this comes from. An EKG is looking at the electricity of your heart. So what can go wrong with the electricity? Well, we can develop arrhythmias, which are abnormal heart rhythms. You can have something called atrial fibrillation, atrial flutter. Those are abnormal rhythms coming from the top of the heart. Also, supraventricular tachycardia. You can have more dangerous rhythms coming from the bottom of the heart. Those are called ventricular tachycardia. Or if there's a problem in the electrical system going from top to bottom, or a problem at the top, you could have heart block and potentially need something like a pacemaker. I will not quiz you, but here's just the overall of how I think about the heart. So why is this related to what we're talking about today? Well, for the cardiologist, so I like to make things very simple for myself because I am not an oncologist by training. I am not a board-certified oncologist, but I work really closely with my oncology colleagues, and I try to do my best to understand what's going on with the diseases that my patients have and also how they're being treated. So when we think about the MPNs. First, as was already discussed today, is this CHIP, clonal hematopoiesis of indeterminate potential. And so this is not something that you're born with. This is something that comes where we have normal cells coming from the bone marrow. Your cells can divide. And then sometime along the way, usually as we get older, you can develop these somatic alterations, meaning they are not something you are inherited with, you didn't get from your mom or dad, but they just develop over time. And we tend to see these more as we get older. So here's CHIP. And then this was already brought up before, but there's been many research studies looking at how does CHIP impact our cardiovascular system? Well, it's very well established now that if you have these specific alterations, you are at increased risk for having strokes, a bleed in the brain or a clot in the brain, increased risk for blood clots in the artery going to the lungs, a pulmonary embolism, increased risk for coronary artery disease, plumbing problems, for pump problems, heart failure and aortic stenosis, electricity problems, atrial fibrillation, issues with the blood vessels, the abdominal aortic aneurysm, and then issues with the blood vessels in the legs is peripheral artery disease. So the takeaway I would say from this slide is if you have alteration in these cells, that you are at increased risk for plumbing problems, pump problems, and electricity problems. So where does MPN fall in with this? Well, we also know that patients who have MPNs, which is similarly associated with some of the same alterations, but a little bit different on the spectrum of when we're thinking about CHIP to MPN, we know that patients with MPN are increased risk for plaque buildup in the plumbing system, atherosclerosis in the arteries, in the heart arteries, in the arteries of the legs, increased risk for blood clots, and then increased risk for heart pump issues, congestive heart failure. So just to touch briefly on the treatments for MPNs, they actually are really well tolerated from a cardiac perspective. And usually when my patients are telling me which treatments they're on, if they're on the Jakafi, if they're on the interferon, I'm not usually particularly worried as a cardiologist. I'm actually more related about the disease that they have that's being treated. That increases your risk of cardiovascular disease. There are some things, if you go on Google and you're looking with these treatments and you listen to the commercials and see the side effects that come up. So I'll tell you some of the things that can come up. Anagrelide is one of the treatments, and it's basically can cause your blood vessels to dilate, which sometimes causes you to have lower blood pressures. For some patients, you can have higher blood pressures. You can develop swelling, extra fluid in the legs, or some people describe feeling palpitations, feeling their heart beating fast or funny, which may be due to an electricity problem or just maybe a sense that they're feeling the heart beating faster. And then the other drug, just to know about if you are on this medication, it can potentially cause electricity issues, meaning it causes delays in the repolarization of the electricity system. And so typically we are monitoring patients on this therapy with ECGs. The last part I will say, if you are going to be treated for your MPN with a stem cell transplant, I work really closely with our transplant doctors here. And so patients will usually have a cardiac evaluation before undergoing transplant because it's stressful on the body. We want to make sure your heart is as optimized as possible to get you safely through the transplant process. It's important to know that during the actual transplant itself, because of chemotherapy, because of shifts of fluids, there are some increased risk of electricity problems, abnormal heartbeats, and because of all the fluid that's involved, sometimes people are at increased risk for congestive heart failure, extra fluid in the lungs or the legs. So again, we try to make sure you are best suited for your transplant before putting you through that process, that we can safely get you through the transplant. So, not to be all doom and gloom and to tell you the things that you're at risk for, but really I want to tell you my goal as a cardio-oncologist is to help my patients, to help you receive the best cancer treatment possible, but I want to minimize the short and the long-term risks for cardiovascular disease. Historically, we've really focused on treating the cancer, which is important. We can't take care of your heart if it's not beating. However, we are doing such a good job at treating cancer these days, it's really important simultaneously to think about your heart and your cardiovascular health. So we're going to talk about the tools to do that. How? Well, I'll tell you there's not great guidelines, and we're getting more data about how to do this. So I will tell you my approach I tend to use in general as a cardio-oncologist, and some things we could talk about specific to the patient who has an MPN. So the first thing is what you all are doing here today. I go through the ABCDEs. I'm a mnemonics person. Medicine's very complicated, and I think if there's anything we can do to make it a little bit simpler, I use this here. So if you're in my office, we're going to talk about the ABCDEs, and these are something that you can talk about with your primary care doctor, with your oncologist, with your cardiologist. Really, everybody should be able to help you with this, or then direct you if you need to see another doctor subspecialist to help you. So what you're all doing today is the A, awareness, knowing that you have a disease that increases the risk for cardiovascular disease. I can see it's definitely anxiety provoking, and so we want to take that anxiety and channel into what can I do to overcome these statistics, to overcome this, and to help me live a long and healthy life without having heart issues, without having to see Dr. Feldman across the street in the hospital for a heart issue. The other A, I will say, is aspirin. So traditionally, we're using doses of aspirin, of just the baby aspirin, of 81 milligrams. So I usually defer to your oncologist if they think it's appropriate for treatment or that you should be on it with your MPN to prevent you from developing blood clots. If you have had a heart attack or a stroke, you definitely should be on aspirin 81. And then there's some nuance. In the news a couple years ago, the United States Preventive Task Force said, well, we shouldn't have everybody on aspirin. It used to be if you were 50 and older, we would give you an aspirin to prevent heart attack. And then there's more data that if you put everybody on aspirin, you're going to have way more people who are having bleeding issues than you're preventing heart attacks. So aspirin is a great medication to use in the select patient population. If you have any questions, I suggest you talk to your oncologist about it. And the other part is that sometimes we need to hold aspirin before you're having procedures. If you're having biopsies, if you're having surgeries, sometimes we'll continue it, sometimes we'll stop it. So it's important to know specifically for you if we think you should continue it or if we think you should hold it. The next one is B. So B is for blood pressure. So I encourage you all to know your numbers. Every time you go into the doctor's office, they check your blood pressure. And so I will tell you, as a patient going into an oncologist's office, your blood pressure is usually high in the doctor's office. Don't freak out. You're nervous, you're anxious. There's this phenomenon of white coat hypertension. And so I personally don't like to treat your blood pressure just based on the blood pressure in the office. However, blood pressure is what your body is seeing throughout the course of the day. And it's also the extra force that your pump has to work against. And so if we can prevent cardiovascular disease, one of the most important things we can do is control your blood pressure. There's different guidelines and different goals for blood pressure, but I would say for the majority of people, we really should try to keep your blood pressure on average less than 130/80. So as I said, your office measurements are usually going to be higher. Fine. So what I usually recommend for patients, not the ambulatory blood pressure monitoring, that's where you have to wear a cuff and you wear it for 24, 48 hours and it goes up and down every hour. That's a pain in the butt. I try not to interfere with your life too much. So I recommend that you get a blood pressure cuff. Arm is better than wrist, though I know some people have discomfort with the arm ones. You should get a validated cuff. If you need a brand, personally, I have the Omron. I am not sponsored. I have nothing from them, but I find that they work, and they have a whole range of blood pressure cuffs. They have like basic to the like platinum version. If you go on Amazon, you'll see all of them. You just need the basic. Don't spend a lot of money, and sometimes your insurance company will cover it for you. But I usually recommend that you check your blood pressure 1 hour after you take your medications. You check it while you're seated, while you're relaxed, not after having a coffee. I won't even say smoking a cigarette because none of you should be smoking cigarettes. But that's the best optimal time. What I encourage my patients to do is at least 3 days a week, check your blood pressure, write it down in a log, and bring it to your doctor's office visits. That way, when you go to see Dr. Abuzena and your blood pressure is 180/100 and he's calling me and saying, oh my God, what do I do for this patient? You say, hey, I'm just nervous to see you today. These are what my blood pressures look like at home. And then I also encourage you to bring your blood pressure machine into the office at least once so we can make sure these beautiful numbers at home are real and that your cuff correlates somewhat with our in-office machine. So that's blood pressure. What can you do to lower your blood pressure if it truly is above goal with good measurements? The first thing is the low salt DASH diet. If you Google DASH, it's basically a low salt diet. So make sure you know what has salt in it in your diet. Don't add salt to your foods. Avoiding fried foods, you have to be careful. A lot of frozen foods have a lot of salt, or sodium is what you're looking for on the back of the label. We're going to talk about, for E, exercise. Alcohol is one that really can increase your blood pressure, so we want you to live your life, but you have to be careful about the amount of alcohol you have because it can significantly increase your blood pressure. Sleep apnea or snoring is another thing that I tend to pick up clinic visits. If you are snoring, your significant other or somebody in the house tells you you're snoring, you wake up feeling tired, those are clues that you may have sleep apnea, and getting your sleep apnea treated will give you better quality of sleep, and it will lower your blood pressure along the way. And then if you are above goal, got to talk to your doctors about medication for that. That could be your primary care doctor. If you need to see a cardiologist, anybody along your healthcare team can probably help you out with that. I will move on to C. I almost forgot to put the no smoking picture because I just assumed nobody's smoking, but I wouldn't be doing my job if I didn't tell you one of the most important C's is cigarettes. So cigarettes exponentially increase your risk for cardiovascular disease if you have a CHIP mutation or if you have MPN and you are smoking. You really like to live on the edge, and you're going to see me in the hospital with a cardiac issue. So I strongly, strongly, strongly recommend that you should not be smoking cigarettes. Talk to your doctors. There's many different tools and ways. There's no one size fits all for quitting smoking, but whatever we can get you to do to quit smoking, we are happy to do, because that is the most important thing beyond adding medications, controlling your blood pressure. So quit smoking. The other C, you guys have heard about today, is cholesterol. And so in terms of cholesterol, it's really important to know your numbers. Make sure somebody is checking your cholesterol at least once per year. There's different guidelines for different people, but I would say once you have a cancer diagnosis, you have an MPN, we should be looking at your cholesterol at least once a year. And so some of the other tricks I would say is you don't have to go get fancy tests. Usually at some point along the way, you're going to have a CAT scan of your chest. They're not looking at your heart, but we actually get a view of your heart. If you look in the report, because all of you now get on your patient portals, your CT scan reports, if you see mention of coronary artery calcification, bring that up to your doctor. That means there's plaque on the outside of your arteries. It doesn't mean there's plaque inside the plumbing, that there's a significant blockage, but it means you're at higher risk for having a plumbing problem. And so it means that we need to be a little bit more aggressive about controlling your cholesterol. So medications are fine, but the first thing is dietary modifications, and we'll talk about diet on the next slide. But diet can definitely help with lowering the LDL, is the bad cholesterol. Through the years, cardiologists have gone back and forth about what matters the most. In 2024, I would say the LDL is the thing we're going to focus on most. That's the bad cholesterol. That's the one that's going to gunk up your arteries and increase your risk for having a plumbing problem, a heart attack. The other thing is to talk to your doctor about medication for LDL above goal. If your LDL is above goal or you have coronary artery calcification, even if your LDL is great and there's calcification there, that means there's some other inflammatory process, something going on that we really need to get you on something. So you already heard a preview. Statins are one of those. There are a whole other slew of tools in our toolbox to help to lower your cholesterol in addition to diet. Statins, I really like statins because of the anti-inflammatory properties as well. Some people have issues with side effects with statin. Muscle aches, if you talk to any of your friends, somebody's going to have a story about statins. I'll tell you that there's randomized controlled trials where you would put people on statins and you put the same, half the group of people on sugar pills, placebo. Just as much people in the sugar group, if not more, actually had complaints of muscle aches than those on statins. Why is that? Because who gets put on statins? People over the age of 50. And who has muscle aches? People over the age of 50. So don't be scared of the statin. There are different flavors, different doses, different combinations. So if you had issues with one, we can try another. But there are newer therapies, things like ezetimibe, Zetia, Nexletol, bempedoic acid, all of these other things. Or if the cholesterol is really high, we have nice injectable medications. They're very elegant RNAi inhibitors that can lower your cholesterol dramatically, and it's an injection every 2 weeks or an infusion every 6 months. So there's things that we can do. So don't despair if you have statin issues, but don't be scared of the statins. D, I would say, is diabetes and diet. So diabetes means that we should know our numbers. We should have our A1C. That tells us our average blood sugar over the course of 3 months. You should have that checked at least once a year. We should know if you have diabetes, and we should treat that because that's another increased risk for inflammation, for cardiovascular disease, plumbing issues, pump issues, and so we want to address that. And so I get asked this question very often, well, what's the best diet? Well, I would say one that's sustainable, but the best literature to date would suggest that the Mediterranean diet is going to be best. So I'd say picture yourself out in Italy or something and think about what are they eating there. So you're going to want to have olive oil, avocados, nuts, grains, salmon, fruits, vegetables. You're going to want to avoid things like fast food, takeout, saturated fats, all of those things. This is the diet that's going to lower your LDL. The other question I'll get sometimes is, what do I do about that HDL, is the good cholesterol? And that brings us to exercise. So we don't talk about this enough because we can't write a prescription for it. But I know some places people will actually put it on the prescription pad. I don't know a way through Epic to do it, and I don't have a prescription pad. So I talk a lot about exercise. So there are guidelines for patients with cancer, but I will say they're the exact same as patients who do not have cancer, is that we all need to move more. And the goal is to do up to 150 minutes of exercise per week. And for our bone health, we should be doing 2 days of light weights. Now, for patients with cancer, I say you cannot use the competitive athlete Olympian model where no pain, no gain, and push through. If you are feeling poorly, if you are having a bad day, if you are just started a new therapy and you don't feel well, do not push yourself and come into my office and tell me that, like, I felt terrible, Dr. Feldman, but I really made myself run up the hill. Do not do that. Listen to your body. I think that's one of the most important pieces to say as we're talking about exercise. So exercise is important. If you're doing nothing, I will say, okay, fine, I will see you back in 6 months. And when I see you in 6 months, you're going to be doing 2 days per week, maybe 10 minutes, maybe 20 minutes. So start slow and build your way up. But I also struggle to get to my 150 minutes, but I do it too because I tell you guys to do it every day. And I know it's good for your cardiovascular health. It's good for your mental health. And actually, there's a lot of data that it also improves cancer outcomes. So exercise, but listen to your body. And so I will end here, but I wanted to give you a couple take-home points if I didn't mention them already, but hopefully nothing is new here. So patients who have cancer are at increased risk for cardiovascular disease. We know patients with MPN are at increased risk for plumbing issues, pump issues, and electricity issues. But the biggest thing is that you should really feel empowered to decrease your risk of cardiovascular disease by following the ABCDs. Use a mnemonic, you won't forget. And really feel empowered to talk to your doctor about your cardiac concerns. And they can direct you if they can help you with that, or as you work as part of a collaborative team with your primary care physician, cardiologist, or if you need to see a cardio-oncologist, happy to help out.
Thank you very much, Dr. Feldman, for a very informative talk. I certainly learned a lot, and I'm sure you all did as well.